Good morning and welcome to News 24's Frontline. My name is Kyle Cowan. I'm a member of the investigative journalism team at News 24, and thank you for joining us today. It's Wednesday, the 20th of May, and it's also day 54 of us all living under some form of lockdown, and 75 days since the first case of COVID-19 was confirmed in South Africa. Since that day, it has been a whirlwind of regulations, endless press briefings by the president and members of cabinet, and we have all been bombarded with news about the newest coronavirus and what's happening and where are the infections. Today, we are joined by Professor Alex van den Heever, and together we will attempt to unpack two key questions about lockdown: where it went wrong and what the future holds. Professor van den Heever holds the chair of Social Security Systems and Administration and Management Studies of the Wits School of Governance. He holds a master's in economics and has worked in areas of health economics and finance, public finance, and social security in various capacities since 1989. He has also held positions in the Department of Finance, the Industrial Development Corporation, and the Center for Health Policy at Wits, as well as the Gauteng Department of Health. Between 2000 and 2010, Professor van den Heever worked as advisor to the Council for Medical Schemes. He has published extensively in the field of health policy, the implementation and review of health public-private partnerships and the regulation of health systems. He's also, I'm very glad to say, a regular contributor of thought-provoking articles to News 24 and can frequently be seen on national television where he's asked to weigh in on the most pressing health issues of the day. Good morning, Professor, and thank you for joining us.
Good morning.
So, Professor, it feels like a lifetime ago that we first heard about, the COVID-19, the first case in KwaZulu-Natal on the 5th of March. And since then, it's like I said, it's sort of been a whirlwind. So what is an average day like for you now? What do you get up, and when you get up in the morning, I see you're in your office, do you head down to your office? And what do you do? Tell us about just a normal day in your life at this moment.
It feels a bit like Groundhog Day. You never escape from the same environment. Every day merges into the next, but pretty much it involves sort of work and a bit of relaxation. You're sitting in front of a television, multiple meetings, the kinds of meetings you never had before, because now they can end and you can transition into a new meeting within a minute. And so those have also accumulated. So every day is pretty much a mixture of that. And at the moment it's marking and online courses, which the universities have also transitioned into. And that's going to be our future for quite a while.
Yeah. No, it's changing times indeed. And I think we have spoken before about the joys of Zoom meetings, but here we are having another one. And hopefully this one will be informative and not so much fun, because it's going to be quite worrying, I think. But I want to take us very, very quickly straight into it. I mean, we have an hour here with you. So last night we were finally made privy to some projections that a team or a consortium of some of the country's foremost epidemiologists and virologists and statisticians had been working on. And it showed us a very worrying picture of the trajectory of COVID-19 in South Africa. And it's the first time we're really seeing this coming from something or a body or a person that is affiliated with our government, that is informing government response. Have you had a chance to look at those projections, and what are your general sort of ideas about what projections are, what they can and can't be used for, and what these projections are telling us?
So the first thing is to look at what models are really meant to be. They're meant to be some kind of a way of confining certain of your assumptions, placing them within a kind of a framework, a systematic framework for analysis, so that you can often modify variables and say, well, if this, then that, within a structured conversation about, in most cases, in the case of numbers. So models themselves are not crystal balls. They are not meant to be attempts to see the future, and they shouldn't be seen or used like that. To a large extent, I've used models not to do forecasting. I'm afraid the international literature demonstrates that epidemiological forecasting is about 25 years behind weather forecasting. And we have to be extremely cautious about assuming that these are a genuine reflection of what's going to happen going forward. In most cases, we really only know a sort of what's going to happen a short period into the future, and all you're doing is extrapolating. And the further in time forward that you extrapolate, the less reliable your results are. So I note in some models, the confidence intervals seem to remain the same over the entire periods, but actually the confidence intervals disappear into the ether within a few weeks in a model like this. So I would not, so the first issue is, how do you use them? You should use them to improve your thinking about a problem, but not to use them as your fundamental determinant for decisions. You have to make very clear what you do not know and what the model may be creating a number for. It creates the appearance of certainty, but it is far from certain. So the further we go out into the future, the certainty disappears. And that is often not made clear. And it produces a number with 3 decimal places, and it looks like it's precise, but it is far from precise and can be very dangerous. So I think that it's good that people analyze, but one must be very cautious about creating false certainty about things that have huge implications in policy. So I think it's a good thing that the model's been made available, but the question really is, how is it being used in the policy-making process?
And of course, there have been some discussions, around the transparency and, sort of the openness of government surrounding some issues surrounding, COVID-19. And I suppose the key question then would be, as you mentioned, you wouldn't use modeling for forecasting, but it can be a useful tool to inform some form of public policy thinking. Are we seeing any responses in public policy and health policy, essentially, that can meet the need, that shows even that we are meeting the need of even the most basic of the forecasts that we've seen so far?
So in terms of interpreting this model and analysis, so for instance, I would have developed a COVID model to assess alternative intervention scenarios, not forecasting. So I'd say if we did this, and 2 equivalent interventions that might have the same impact but have different, let's say, economic impacts, you'd want to compare how long and how damaging would one version or one package of interventions be in comparison to another package of interventions. So under those analyses, it's quite useful to try and make a decision between where you place your weight in terms of a policy intervention. So I'll give you an example of that, and it's important to where we are now in terms of government policy. If you look internationally, testing and tracing is effectively an equivalent to the impact of a lockdown when it's introduced at a time when the epidemic is at a relatively low level. At very high levels, when you've let it run away from you, testing and tracing falls away as an option. But if it's introduced early, it is a very serious option. So countries that have done that have not gone into lockdowns. So if you had to look at the UK at the moment, the UK is essentially trying to get its epidemic down to a level that it can switch over to testing and tracing as its key strategy. So they are essentially alternatives. Within the South African context, the model that's produced suggests that there's a surge and a peak sometime in September. And I've never seen a trajectory like that in other countries, certainly not after an extensive lockdown. Usually after an extensive lockdown, you've suppressed the epidemic substantially so that you can control it using other means. But when you show that, in fact, your lockdown has not achieved that effect, it's just subdued, reduced the amplitude of the epidemic, it confuses me because it doesn't appear to be the way it has worked elsewhere. And it also doesn't appear to be a rational way of evaluating our policy alternatives, because what this is suggesting is that our only strategy is to try and get more beds, not to actually introduce better prevention to suppress the epidemic, better non-therapeutic interventions to suppress the epidemic. So it has been eminently possible for us to suppress the epidemic using testing and tracing, for instance. And we failed basically to implement that at scale. So right now, we should have been, just on the National Health Laboratory Services side, according to what they indicated, at about sort of 36,000 to 40,000 tests per day, excluding the private sector. So the private sector is testing around about 6,000 to 7,000 a day. Public sector at the moment, that's the NHLS, is about 7,000 per day. By comparison, it should be at sort of 4 or 5 times that level. We don't know the constraints to it, but they've essentially taken that out of our toolkit for the moment as a major method of suppressing the epidemic. So we are uncertain at this point as to the extent to which the strategic use of testing and tracing is a feasible method of suppressing the epidemic on a wide scale. But that would have been if you were evaluating alternatives, that's what you would be driving your models to show. This does better than that, and this is cheaper than that. Therefore, we do this.
So, bearing that in mind, and we know that contact tracing and screening, exceptionally important tools as part of the toolkit. But at what point does contact tracing and screening, if you haven't implemented, like you said, at an early stage in the epidemic, when you have a low number of cases, and you haven't implemented it well, at what stage does it become almost irrelevant to trying to handle the epidemic? Certainly, there must be a point where you say, okay, we can't contact, trace, and screen all the people in the country. So what we're going to have to now do is change that and shift that priority towards ensuring hospital readiness to just try and anticipate, that sort of avalanche of patients. Do you think that we have reached that point yet, or do you think there is still time for us to sort of try and bring that contact tracing and screening program up to par?
So in my view, when you've reduced your strategy to trying to create hospital beds, you're effectively reduced your strategy to digging graves. It's essentially an indication of failure because your contingency has now been realized. The worst case contingency has been realized, which is an epidemic at such a level that you don't really have an ability to contain it. And this is a problem I have just decided again on the model, is that the reduction in the amplitude is assumed in the model, I think is false, because at a point in time when you pass through a threshold, some of your interventions become worthless, and therefore you could potentially have a higher escalation, a return to a higher surge than you would have been. It shouldn't reduce the amplitude necessarily. On the other hand, to answer your question on what interventions would work if we haven't really got testing and tracing up to scale, I think that firstly, just on that point, government really does have to be put under pressure to get testing and tracing up to scale, no matter what. They must get their house in order. They have to lift the priority around testing and tracing. There's no country in the world that puts this as your sort of hidden last priority, which you'll notice that it's kind of disappeared from the narrative, which is to me a very dangerous sign. It means people are avoiding saying that we can't do it. However, we have a number of other interventions in place. We are not intervention free. We have closed borders. Aside from the lockdown, we have now a constant increase in the usage of face masks, which is has a very definite impact on the reproduction rate of the disease. We are going to, as we reopen with businesses, we have health protocols in place. And if there is somebody where there is somebody tests positive at a workplace, there's an immediate reaction to that. Now, think back 3 months, that wouldn't have happened. So you can expect the reproduction rate of the disease to be much higher. You'd be less cautious at a supermarket than you are now. Now people are hyper cautious, and with or without a lockdown, they're going to stay that way. We have churches that are closed. We have funerals that are restricted in size, not small enough in my view, but restricted in size. We don't have people going to movie theaters and to theaters. So all of those would have been normal in January and February. They are not normal anymore, and they're going to remain. So you can open up the economy, but a hell of a lot of things will remain in place that do reduce the reproductive rate of the epidemic. densely populated communities are always going to end up with a higher prevalence at the end of the day, because even with those, there's a degree of sort of infection that's kind of unavoidable. But the question is really, when taking into account your other prevention mechanisms, at what point does it turn down? So the epidemics might, in the South African context, end up being very localized to areas where you'll rise and they will decline in a local context. And so when you have model analysis that is very aggregate, putting numbers together, it completely divorces itself from the real nature of the epidemic, which is a combination of exploding epidemics at a very local level and ones which will never rise very high. So low density communities, people in rural areas, suburbs, those kinds of areas are never going to be high risk, again, taking into account the prevention mechanisms that are in place. So the question is, when you take that into account, what's our trajectory likely to be? And I think that if we are targeted in our measures, that means that even if you continue with lockdowns, they are not necessarily broad-based lockdowns that just arbitrarily shut down all businesses and all sort of areas, whether they're low risk or high risk. You lock down an area for a small period of time and you address the epidemic in that area and move on. That means you concentrate your use of resources on a targeted basis around hotspots. That, even if we've got a failure to expand testing and tracing to the scale we would like, still allows for strategy. And that's in fact what we need, is targeted strategies that are consistent with us keeping the economy open, but keeping people safe at the same time. And we have no choice but to move into that mode. And if we don't get testing and tracing up to scale, we have no choice but to use all the other tools in our toolkit to manage the epidemic. And that means localized interventions, targeting, smart strategies with minimal resources that have leveraged effects. That's going to be our only route forward if we've got a virus. It's going to be with us until we have a vaccine. And that's quite a while. And lockdowns are just not sustainable within that context.
You know, and then there's this other narrative that has emerged, Prof, from this lockdown, and we're seeing this, you know, on quite a regular basis from our government leaders, in that we have successfully flattened the curve. This is a term that you took some umbrage with in a recent article for News 24, but I'd like you just to walk us through that again. Why is it that we haven't flattened the curve, and what does it mean?
Well, so one of the things that I don't like is the use of the term in such arbitrary ways. People are just reproducing what somebody in WHO says and politicians say in the UK. The underlying viewpoint behind it is that we are reducing the amplitude, that's one way of doing it, of the epidemic. In other words, minimizing the peak so that everybody can get a hospital bed. In other words, they're not actually attempting to stop the disease. They're not attempting to suppress the epidemic. They're actually saying, all we're trying to do is to suppress it sufficiently for us so that at no point in time are we going to run out of beds. Now, that is not necessarily the most coherent strategy. If we can suppress the epidemic without and reduce the need for any hospital beds, even if there's a likelihood that the disease, that there's a resurgence. So the question is, what is really the strategy? Because if that's the purpose of flattening the curve, which is what people have been kind of repeating all over the place, it's a bad strategy, because we won't be able, if we let the epidemic get to the levels where we are hospitalizing up to peak, we can't control it going beyond. And that to me is the real concern. This model suggests that people are almost expecting to completely lose control of the epidemic. That is a strange policy target to have. I think that because so many people who get infected, even when they get to hospital and require ventilation, they die. 80% to 90% die. So if having more ventilators is not going to save people, stopping people from needing them is going to save people. So I think that the whole narrative associated with flattening the curve is suggestive of a strategy that almost is suggesting that the strategy is to fail. Is that we are going to let people go to hospital, and all we're doing is buying time so that we can put up more camp beds. That is, so the issue is that if our strategy was instead that we're going to use our time to implement our other prevention mechanisms that will stop people needing hospital services, then that's a worthwhile strategy. You won't need more hospital beds. So so to me, it's unclear what the sort of policymakers, as opposed to the analysts advising them, have really understood about the strategy that's implicit and what strategy they're informing. Because if we go to South Korea or New Zealand or Germany, none of them would be thinking of this strategy. And the UK got into trouble. What they're now trying to do is to get to a level of the epidemic where they're going to keep people out of hospital.
And of course, this raises then a next question. We've been speaking about raising hospital bed capacities and getting ventilators from the very beginning, because we were looking at other countries across the world, and I think myself and some of my colleagues in the media, we're also guilty of, I think, placing an overly strong focus on ventilators and bed capacities, with good reason, I think. But it has almost been a talking point from the very beginning. I recall a presentation by the Director General for the Department of Health, Dr. Anban Pillay, the Acting Director General, pardon me, and he gave a presentation to Parliament around the 10th of April, in which, they expected, we'd need so many ICU beds, and as part of the presentation, we'd need so many ventilators. So what you're essentially saying, Prof, is that having this as a key part of your strategy from the beginning was potentially, quite a glaring oversight in terms of what we should be trying to prevent, instead of trying to, as you said, dig the graves before we've treated the patient. Is that something that you would agree with?
Yeah, so first of all, I published an article before the lockdown in which I pointed out the risk that we would have based on the number of ICU beds as a proxy indicator of the number of ventilators that we have in South Africa. And then extrapolated from the Chinese experience, which is predominantly Wuhan, to say, if that happened here, we will run out of beds. That was not a forecast, not a projection. It was as I go back to the point, it's a contingency. It's what can happen, not what will happen. So what you're doing when you show that is to say, don't let this happen. The other warning was to say that if we reached a situation just with Wuhan, we would need to have a very high degree of coordination between public and private sector to ensure that we use all available beds for the entire population if this happens. So that was the second contingency warning. Get your act together. Get a public-private partnership on access to all these beds. And that wasn't in place then, and is effectively not properly in place now, which remains a concern. I want to distinguish between two types of bits of information you want to produce. One is the information on the contingency. What is the risk of something happening? And you want to prepare for that. And the other is your strategy, your strategic objective, in which you do not want to realize your contingency. You want to avoid it. What appears to have happened is that they've made the contingency the strategy. And that is a problem, because the strategy must be, this is the level at which we will suppress the epidemic, and these will be the consequences. But if we lose the battle, here's what happens. We appear to be preparing our approach based on losing the battle. And that worries me, because it means that then government is underinvesting in certain interventions because they think they've already lost the battle. That's a dangerous scenario.
So it sounds quite worrying, Prof, but let's take that scenario as true. Let's say that the South African government has now accepted its contingency as its strategy, and now we have essentially focused from day one on getting the wrong things up to scratch. So now we implement this lockdown. We implement this very hard lockdown where businesses are closed and restaurants are closed and people cannot leave their homes. And it's quite an extended one. It's almost 5 weeks long. And then you tell the country that at this time that this lockdown is actually because we need time to prepare our hospitals. That was the key objective. We were always told we need time to get the hospitals ready, to get PPE for our healthcare workers, which again speaks to your point, which says that we were preparing the contingency as the strategy. We were, from the beginning, we were saying we need to lock down the country, stop importation of cases, stop people moving around immediately so that we can get the hospitals ready, because this massive surge of cases is going to come. And the words, I believe, used by the president and the health minister were the calm before the storm. So now we're at a point where we're starting to ease out of this lockdown. And we can have probably another 2-hour-long conversation just on the regulations that were put in place and removed during lockdown, but I don't think that's necessary for now. But where we are going now is essentially we have seen a rise in cases during this lockdown. We have seen that in areas, particularly in the Western Cape, a hard lockdown has not been effective. I do not think that we can argue that it has been in that specific context. And we are moving towards this sort of eased phasing out. But are our hospitals ready? Is the country well educated enough to understand the social distancing rules? And have we actually achieved this key objective, which is, let's say it was a good strategy, which you've clearly pointed out it might not be, but let's say it was a good strategy to focus on our hospitals. Have we actually done that?
Yeah, and it's difficult to say that we've achieved that. What's been happening is people have put up beds. You need to contrast that with the sort of Nightingale hospitals that were set up in the UK. Those are beds with ventilators. There they would have had to transfer staff if people came through there. They were never really fully used because, in fact, they did turn the epidemic down. But I want to point out one feature just in relation to that. In the UK, the lockdown caused the reproduction rate of the epidemic to decline below 1. So within the South African context, it appears to have remained above 1. Full lockdown, same period. By the end of the lockdown in the UK, they will switch to testing and tracing as their key strategy. In South Africa, we're potentially promising to extend the lockdown. So this is one feature of the strategy that needs to be questioned. But I'll focus on responding to the answer to the question you posed. In terms of bed readiness, it is impossible to tell because beds are not just beds, it's nurses, how they're trained, how much PPE is actually available on site. Will it be sufficient if we have a surge in patients? It's impossible to really tell. The modeling framework that's produced, which I say overestimates by sort of very high degree the likely epidemic, shows that we will be completely overwhelmed. There's no way of surviving what's in the model. There's no way. Yeah. So there's no way of being ready for a complete catastrophe. But we would be potentially ready for a relatively small catastrophe. But if we lose control of the epidemic, the small catastrophe won't stay small because that's the nature of epidemics. You have to have something that makes the trajectory of the epidemic turn down. And if you've got no more bullets in your gun, it doesn't turn down until it runs out of people to infect. That's how it will work. So if you're planning to lose control, you can't be sure you're going to have a small epidemic. So and one that's sort of suppressed to some sort of degree because the very assumption you're using is that you can't control it. So I think that we can add more beds. Most of the beds that we've been adding to various places are purely for the purpose of quarantining people. It is completely unclear how those beds would be serviced. And in many cases, we will be having to use people in general ward beds within hospitals where they've got isolation, where they're isolated from other patients who now aren't coming to hospital. So then in terms of ICU and ventilators, we could double the number of ventilators that we've had and we'll still be swamped. So it's not really a way of dealing with it. And 80% of the people who need ventilators die anyway. So don't let them get there. So so I think that is, so there's just so many concerns around the overall approach that I think, and even within that context, the assumption of any level of appropriate readiness can't be made at this point from that perspective.
Prof, have we done anything right?
I think that we have. I think that the initial lockdown had merit, provided it was part of a strategy. Part of a strategy to suppress, in which I would have described two kinds of strategy. One which is called lockdown dependent, in that our only strategy is every time the disease resurges, we use a generalized lockdown. That basically takes away half our GDP by the end of the year. And the knock-on effect of that is so catastrophic in every respect. We lose control of society at that level. You can't even imagine what that meant. So a lockdown-dependent strategy will always fail in the South African context. You cannot afford it. So your lockdown can only be in for a temporary period, and I feel that was right. The question is what we're using that time for. And now we're seeing constantly we're using that time to get extra beds and bring in Cuban doctors, and maybe get some PPE in place. But what they haven't said is that we've actually got an effective alternative prevention strategy that will still bring the reproduction rate of the epidemic below 1, because you can. And what was good about the period in which we introduced the lockdown, it was early in the epidemic. So its initial effect would have been to suppress transmission from the more affluent communities, who were the importers of the disease, into the general population. That was an important thing to try. It just slowed that. But it would have been impossible, even with the lockdown, to completely stop that. We still started too late to prevent that transmission effect. But once it's in the general population, you then have to accept that you've got that the initial strategy of the general lockdown may no longer be the most successful approach. What a general lockdown is effectively doing is it's closing off the bridges between communities, high risk, low risk communities, and it closes off transport routes. It stops you from being from people from one community affecting another community when they all visit the same shopping center. When the children are all within a school which has multiple communities that it supports. So all of those bridges, a lot of them are closed down during a general lockdown. You can also manage those risks without a lockdown. And but that's the one thing that we would have had at that period. So it definitely would have slowed transmission. But once it's endemic within a particular localized community, it then depends very much on the community dynamics and how successful certain prevention programs operate within that community. You can't assume that what works in one community works in another community. So some epidemics will reach a high level of prevalence in these localized communities, and in others it will be a low level of prevalence with exactly the same interventions. So we're currently running through that scenario. So I think that we have been put in a position where we can manage this epidemic going forward. There's no certainty that that will happen. We will see within the next 2 to 3 weeks, perhaps the next 2 weeks. And that will tell us, are we in trouble, or are we actually curtailing the epidemic with our current interventions? But we can't be totally sure at this point. But I do think that the initial lockdown was an appropriate measure. I think that the problem now is we cannot be addicted to the lockdown as a measure, and we have to use the alternatives to suppress the epidemic. The economy has to be reopened. We have no choice. We just do not have a choice. Whatever it does, we have to open it up, because the devastating collateral impact that has on society cannot be sustained within the South African context, and it can't even be sustained in New York. So you have to always accept that a generalized lockdown is a temporary intervention, and it's not one you return to if you can avoid it. But in some cases, even if the epidemic is going to go, is going to sort of run through society, we, at that point, on the balance of risks, will not be able to use a lockdown again, a generalized. So I think that there is no choice. We have to move to a completely different intervention framework, and it has to be a lot smarter than the approach we've used thus far. Noting that it's a very easy government measure to just shut everything down. It's much more difficult to be smart about it, to be selective, to use surveillance information to target interventions, to have smart platforms that allow very quick and immediate responses, which is what you'll have in the successful countries. So we have to move from the crude strategy to the smart strategies. And we have to move, and we have no choice but to move to that, or we will have an epidemic with an open economy because we can't close it again.
Yeah. And speaking of the economy brings me very neatly to my very next question is, of course, epidemics like this cost a lot of money. And that's something we don't seem to talk about a lot at the moment. I mean, every time the president speaks and the ministers speak, they do tell us that we've raised so much money and we've got commitments of so much money. But I recently saw an article published by Business Insider, which showed that on average, a COVID patient cost about 150,000 Rand to treat if they required an extended sort of term on a ventilator. Can we afford this epidemic? Can any country afford it? And what are the longer term costs, not only monetary costs, but an extended lockdown leads to higher levels of income degradation. People lose their incomes, they lose food security, they lose the ability to go to the shop and buy food because they don't have any money left. And then there's an associated health cost to that too, is there not, Prof? That eventually we're going to see malnutrition cases or other diseases which are communicable but not as highly infectious also starting to rear their heads a little bit again as the entire health system focuses on COVID and sort of moves away from dealing with the other epidemics that we already had ongoing in the normal sense. Can we afford this thing in the long term? And what can we do to sort of try and help those costs to make sure that we survive COVID but don't die from something else?
Yeah, so it's kind of funny that the way in which COVID kills most people is an overreaction of the immune system. That's kind of funnily, oddly enough, kind of what might happen with our attempts to avoid the deal with the epidemic, is that our interventions actually kill us to suppress the epidemic. So if we had to compare the direct costs of, for instance, treating, or even the full cost of alternative prevention approaches, let's say testing and tracing at massive scale. If we had to look at testing and tracing at massive scale, so exclude for the moment the treatment costs, we could go up to, say, 20 billion Rand a year on an annualized basis. That would be just under 2 days cost of a lockdown. So the lockdown itself costs, in terms of lost GDP and economic activity, around about sort of 13 billion Rand a day. That includes about a spot impact of about 10 billion Rand, and then a knock-on effect extrapolated over the entire 12-month period of about 3 billion. So that's per day. So when you start to do those numbers, it very clearly focuses your mind on the kind of strategy you have to think of. What it suggests is whatever it costs to suppress the epidemic is worth doing the direct cost. But the lockdown is the strategy that destroys you. So the lockdown should never, ever be the generalized, blunt instrument of a lockdown. Can never be used other than for a very short period of time. 2-3 weeks, and we should have been moving out of it. So all of our intention during that period should be spent on the alternatives, no matter what they cost. That's the one decision point around it. The impact of the lockdowns themselves are so complex. Already the causes of inequality and poverty within the South African context involve the examination of very careful, detailed dynamics of how society works and how it distributes income and how it distributes wealth in the economy. And these are, very, they're unseen but very complex systems that are at play. Now what we've done is that we have intervened arbitrarily at every level of that system without a clear plan. And what you don't know is what you've cut off. We can't replace them with crude government programs like social grants, food distribution, which itself is a disaster, and support from the UIF, which is, has been also arguably a disaster as well. With tax breaks and those, they don't re-knit your society and your economy together. So the problem is that a lockdown has such a multifaceted impact across everybody, supply chains, businesses. So when somebody loses their income, so let's say they were upper middle income and their business has to shut down, they stop buying things. And when they stop buying things, somebody loses money, they go down. So the question is, what sustains the circulation of money and goods in the economy? We've hit both supply and demand side simultaneously. So now we've moved potentially several million people into destitution that weren't there before. We have no real way of reaching them. Our government structures and platforms are too unsophisticated and too underdeveloped to provide a sort of a support structure for any interim period, even the first 35 days. Then we look at the fiscal impacts. So the fiscal impacts of this are enormous. Once we've knocked out businesses and people have lost income, structurally, government revenue drops. Government expenditures are meant to stay the same. They now have to borrow for the difference. Now the question is, can we borrow? There's a risk that when the gap becomes between your tax revenue and what you're spending becomes so large that nobody's a taker in the capital markets for your bonds. There's a risk that that could happen. If there's now a generalized view that in fact you can't trust government to repay its loans because in fact the deficits are now so large that nobody can understand the consequences of what's going on. Nobody can really see what's going on. So everybody becomes risk averse. So do you take up those bonds? And if government can't access capital markets, it can't pay for the gap. So then you stop paying nurses' salaries, doctors' salaries, teachers' salaries, policemen, the soldiers beating people up. All of those can't be paid for anymore. So what then happens? That's the government side of the picture. So a lot of people think, oh, well, that's what happens to the private sector. Oh, well, it doesn't really matter about them. They were just making profits and excess money. Unfortunately, everything works together as part of the system. Governments, the more we go on, the more unsustainable government becomes. So these are the implications that have to be seriously thought through. The fiscal strategy for not the first 35 days, but for the first period, the first 21 days, was already a catastrophe. 35 days now changes the catastrophe to an even bigger number. And any continuation now changes it to a massive number. And what's now happening is people can't comprehend the consequences anymore. So whereas North America and sort of Western Europe and parts of Eastern Europe will actually bounce back, we may not, because we are not essential to international markets. And some businesses might continue on those, but what's happened to our domestic context from an economic perspective? And nobody can be completely certain. So really that's the kind of big picture here. We've got so many knock-on effects, and all of those also then generate burden of health, burden of disease effects as well, including deferred and delayed treatment. So it just hits everywhere at the same time, and none of our systems are really resilient enough for such a shock.
Well, Prof, that's quite worrying. I mean, we don't often sit and think about COVID-19 beyond, sure, I wonder if I've got it. I wonder if my family's going to be safe from it. I wonder if I'll survive if I get it. And you know, as a journalist, I often speak to people such as yourselves, and it's often quite difficult to hear things like this, because you sort of want to say, but Prof, there must be a silver lining to this cloud. We have to find some hope somewhere. And unfortunately, what I'm hearing now, and I want you to just walk me through this, pre-COVID-19, before we had this epidemic, we already had a health system that was under severe constraint. And we had an economy that was struggling, really limping along, downgrade after downgrade. And now this epidemic comes along, and it sort of devastates all. And the decisions made to try and prevent it devastating all devastates even further. So in the immediate term, if you were, say, the president of the country, what would you do immediately today to sort of try and stem the bloodletting?
So the first, one can really define it only in terms of a strategic approach. To me, the strategic approach means that you've got to examine what we do at every step based on a balance of risks. The balance of risks is not only COVID. The balance of risks is everything. It includes what you do to prevent COVID. So your indirect and direct intervention arrangements. We have to be very clear on what's really important to the sustainability of society and the economy in doing that balance of risks approach. So it means which interventions are very short and sharp and go away, and which interventions take over. What risks are we prepared to accept? Do we understand our contingencies? So in terms of an approach, we haven't followed a balance of risk approach today. We haven't looked at the impacts on wider society in a holistic way as part of saying, should we do this or should we do that? We've looked specifically at COVID-specific risks, which is not sensible within this context, regardless of your or my individual risk. It's basically everybody's at risk of dying of something. A heart attack, some other kind of disease, TB, HIV, everybody's at risk of those things. So when you overemphasize one particular intervention, you diminish how you're evaluating the importance of all of those others. So our strategy should be about bringing people out of poverty. They should be about basically growing the economy, diversifying the economy, making that work. We haven't even taken that strategy into account. We've assumed we can just re-stimulate the economy back into existence after this. That will happen in China, and that will happen in the US. It won't happen so easily here. So we don't have experience of this. So as part of your strategy, you don't take chances about things you don't understand, which has been done. We don't take chances with the economy. You do not. And so that would be the key thing. And taking that forward means that a very, very focused strategy on COVID prevention, not treatment, but COVID prevention as a strategy until we get to a vaccine. Number two, the intervention is consistent with an economy that is open. And you manage the risks of opening the economy by focusing your attention on those areas. The idea that you're just going to shut everything down if the trajectory goes up is now at this point utterly insane. And if you had your strategic thinking right, you would never even be thinking about that. So I think that really has to be the approach, a balance of risks approach, reevaluated at any point, taking into account all risks and not merely COVID risks.
And Prof, that brings me to the last point of discussion, which you and I have discussed before at some length, and it relates to, you've given us a pretty clear outline of what hasn't been done and what could be done to help us in this time, but we don't know what government strategy is, do we? We haven't seen any clear documents or any clear data that tells us that government is implementing A or B strategy across the board, whether it comes to testing, whether it comes to economic stimulus, whether it comes to whatever. Do we have that data somewhere? Is it hidden in a locked vault, or are they simply not thinking about it?
Yeah, so it's very difficult to tell what people are or aren't looking at in a very secretive council. But what one would have expected to have surfaced would have been a strategic document on our overall approach and what's being taken into account to make those decisions. So as I said, if there's an approach, you don't have to give, so there's one part, this is how we're thinking of the problem, and therefore this is what we're doing. What we have that's public is just the level structure and what goes into those levels. And what we're seeing as a decision-making process is something largely seat of the pants. Just as it goes on, somebody makes a decision and they implement that decision. People are scribbling regulations behind the scenes outside of any clear plan. I mean, that's why we have these ridiculous requirements for apparel. That doesn't make sense. That shows very much a seat of the pants decision-making process. So quite a few other countries, they actually have strategy documents. They show their strategic thinking. This is how we're understanding the problem. This is how we've created. This is what we know. This is what we don't know. So these things may change. These things we will act on at this point. Those things we don't know have some contingent implications. Therefore, they're risks in our plan. And that might change what we do on a day-to-day basis. But this will be our approach to dealing with it. Now it becomes clear. So I think at the moment, the problem is that the level structure that has been created suggests that you trigger movements between levels based on new infection rates. And if the new infection rates are rising in a contradictory pattern over time, then if you are following a balance of risks approach, you wouldn't have new infection rates as your trigger. You would have something else, because new infection rates for COVID might be a relatively small risk in comparison to your balance of risks. So you want to see what are the true risks and what do you trigger and what are your contingencies for each of those. And I think that that type of strategy we're not seeing. And it's not even entirely clear that the new infection rates actually would drive movements between the levels. It appears they're making it up as they go along. So sometimes right at the beginning, people sort of suggested that and they walk it back. And then they say they're worried about the Western Cape and maybe we will just have a provincial approach. That doesn't sound like anybody's really thought anything through or anybody really analyzed the data or understood the balance of risks, even for the Western Cape. So I think that is, this should change, because there's a lot of resources available within government to do this stuff intelligently, and there's no risk in making a strategy public. Even if it draws criticism, that's a good thing. Governments see that as a bad thing. They see the press as a bad thing. We're being trashed by the press. The Ministerial Advisory Committee of Scientists make us look bad. Fine, that's part of a democracy. And that helps make better decisions, makes government make better decisions. When people want to hide decisions, it means they haven't thought things through. They don't want to be embarrassed in public. Never a good reason to actually hide stuff. But I would suggest that the reason we haven't seen an explicit strategy is because there isn't one. And it's being made up as we go along. And in fact, they need to start thinking more strategically with the kind of people who can.
And you mentioned it very briefly, you know, there was obviously some criticism of government's response being unscientific, you know, from one of the members of the Ministerial Advisory Committee over the weekend, Dr. Glenda Gray, the CEO of the South African Medical Research Council. Is, in your opinion, from what you are seeing as someone who is obviously also plugged in slightly into those circles, are you seeing any reliance on scientists and experts and academics to help inform any of the strategy, or is government saying, listen, chaps, we don't really have the tools here. Can you come and help us, please? Or is it more of a, we'll ask you the questions, you give us the answers, and we'll make the decisions ourselves?
Yeah, so I think that is effectively the approach we've seen. I think that there's a risk that that some people within government have seen the National Disaster Act as a huge opportunity for other stuff and not for what it's designed for. And within that context, you're not really listening to advice. And so there's a risk that, in fact, the scientists would be used purely as window dressing for decisions you're making based on other criteria completely, unscientific criteria, political criteria, your own long-term agendas, your sort of pet projects and plans that you've had for years and not being able to implement them because of democracy. So this moment in time is one where that temptation might have come out. and it might explain the decision making. That's an hypothesis. But in this framework, in this process, and this kind of crisis, when every decision has huge implications, which businesses survive or die, which people get shifted into destitution, basically who lives or dies in South Africa. And then to say, we're going to make those decisions in which we don't have a proper advisory structure, and we're not going to even listen or ask it competent questions, then you do have to raise sort of questions. That may change because of the fact that people have raised the problem. But as I've said, even the scientists that they've grouped together are going to struggle to create a balance of risk approach, depending on their expertise, to talk on things outside of virology and epidemiology. And so I think that government has not made use of advice in its decision-making process that it should have. It doesn't mean that government has to take that advice, but it means that you respect that as part of your decision-making process, because you're always looking at lots of bits of information. And if you're honest about wanting to operate in the public interest, you will balance out features of what's being told to you and make a decision that is in the best interests of the population, taking into account complex pieces of information. But if you don't even want to ask the question, it really worries me about, what public interest version of the public interest are you chasing? Because you would not disrespect the views that are coming through. You would take them into account, even if you do something different. But they didn't even ask the question. And that to me is a problem.
Well, Prof, I mean, it's been a very enlightening discussion, and we've got a few minutes left on the clock before I unfortunately have to let you go. I suppose, again, I'm trying to find some form of hope. I'm trying to find a good takeaway to say to me when I go home this evening, and when our readers log off after listening to our conversation now, and they turn to their husbands or their wives or their children, and they say, well, things are quite bad, but I think we have one thing going for us. In your opinion, what would that one thing be? Would it be our resilience as a country, that we've always somehow managed to bounce back, not from something as serious and as widespread as this yet, but somehow we've always spook and plucked and made it work and sort of carried on? Is that something that you can see us doing in this situation?
Well, without saying without true knowledge of what's likely to happen, I think that there's a higher probability of us getting out of this than actually permanently falling into a dark hole. I think that an important feature of this is how government acts on one hand and the rest of society. But government, people shouldn't be complacent and say, okay, we're just trusting government officials to get on with it. I think that if people have a healthy disrespect for government strategy, demand answers, say we don't just trust you with everything, it will actually result in better decisions by government. And we do actually require those at this point in time. So that would be a positive. And I think that South African citizens have been sufficiently rebellious over the past 70 years to question and make that healthy disrespect work in their favor, because that is what democracy is about. It is about correcting and balancing what government does. I think the other is that we will be seeing in the near future, we will have a stimulus package. We will see an international and worldwide stimulus. I think a lot depends on how much damage we experience now and what government does in the next 2 to 3 weeks. We've got to change our approach to the economy. And the faster we do that, the faster we will basically heal going forward. It's probable that a lot of those sort of the stimulus will impact mostly next year. But I think that society in general can recover from this. Actually, countries do recover. You look at post-war period, cities bombed flat, people do emerge out of this, and healthy, balanced societies can emerge. But I do think we need to be very, very vigilant and careful, and I think that then we will emerge. And we do have to try and look for a healthier debate about what our society looks like as we emerge out of this, rather than sort of demagogic, absolutist solutions to and corrupt proposals for the development of South Africa. I think we have to build an equitable, healthy society afterwards.
Thank you, Prof. And that has been a delightfully instructive hour with you. And yes, looking forward, perhaps COVID is not the killer of us all. Perhaps it is the changer of our society. Perhaps it can bring about some structural reforms to our economy that can really start to change the way our economy works. Prof, thank you very much again for your time, and hope to have you on again very soon.
Thank you.